Hello again, I'm Dr. Jack West, medical oncologist in Seattle, Washington. In my last video, I covered some of the clinical highlights from the Empower 150 trial, at least the preliminary presentation that we've gotten thus far in late 2017. There was also an intriguing presentation of some of the biomarker results from this that really merit a separate discussion here. Just by very brief summary of the Empower 150 trial design, it enrolled just over 1,200 chemotherapy-naive patients with advanced non-squamous non-small cell lung cancer, and there was no threshold level of PD-L1 expression required. Any level was okay, and you just needed to have tissue available for study. Unlike many first-line trials with immunotherapy, patients with an EGFR mutation or ALK rearrangement were not excluded from this study. They comprised about 14%, and in this trial, they just needed to be chemotherapy naive. So most, or I believe nearly all of them, had received prior targeted therapy against the relevant driver mutation. Now, patients were randomized to, in a 1-to-1-to-1 fashion, to one of three arms. The control arm, arm C, was carbo and paclitaxel with bevacizumab, which is a 3-drug combination that is one of many reasonable, commonly used regimens in the US and in other parts of the world. And there were two investigational arms. One was carboplatin and paclitaxel with atezolizumab instead of bevacizumab. That was designated arm A. And arm B, which was the main focus of the early presentation of the data thus far, gave atezolizumab along with carbo, paclitaxel, and bevacizumab. And there was a maintenance component for all of these in patients who had not demonstrated progression after 4 to 6 cycles of treatment. Let's turn to the biomarkers. The PD-L1 expression in this study, like the other Empower trials sponsored by Genentech and Roche, used the SP142 antibody. It performs comparably to the more commonly used 22C3 antibody, that's the companion diagnostic for pembrolizumab. The definitions of what constitutes high level or not are a little different, but really functionally pretty comparable. What's more novel is the biomarker they designate as T effector gene signature expression. And this is a messenger RNA expression of 3 different genes that serves as a surrogate for PD-L1 expression and pre-existing immunity. And that's interesting in theory, but in practice, when they looked at some prior data with the OAK study, that was a randomized phase 3 trial of atezolizumab versus docetaxel chemotherapy in second-line advanced non-small cell. The T effector gene signature was a more sensitive biomarker for progression-free survival benefit than PD-L1. Of course, PD-L1 is more widely used, but it's not one that is a great biomarker, and the question is, can we do better? Would T effector high-level gene expression be a better choice? This was built in as a prospective variable in this particular study. And when you look at how the patients ended up, it was about, as I said, 14% of the patients had an EGFR mutation or ALK rearrangement. High-level T effector gene signature expression was seen in about 43% of patients, and high-level PD-L1 expression was seen in just over a third of the patients in the study overall. So when you look at the progression-free survival in just that subgroup, a little more than 40% of patients with T effector high gene signature expression, the results are really very interesting, because there was no difference in the outcomes in the patients who just got standard treatment in the T effector high versus the broader population. Median progression-free survival is 6.8 months in both of these groups. On the other hand, in the recipients of atezolizumab, that 4-drug combination, The median progression-free survival is over 11 months. So that's a 4.5-month difference in median progression-free survival with the T effector high gene signature level. And the hazard ratio is 0.505, so an approximately 50% improvement in progression-free survival in this large subset of patients. When you look at the landmark analysis of, say, 12-month progression-free survival, it's a more than doubling of progression-free survival at that point, 18% versus 46% with atezolizumab in combination with carbo, paclitaxel, and bevacizumab. So when you look at the forest plot, the different biomarker-defined subgroups, several interesting results emerge. And I think one of the first things we should focus on here is the EGFR and ALK positive population, because this is a group that we have generally presumed get little or no benefit from these immune checkpoint inhibitors. In subgroup analyses in the second-line setting of various checkpoint inhibitors, the EGFR mutation positive patients really seem to do no better with these immunotherapies than with docetaxel. And our anecdotal experience with ALK positive patients has really not been any better. On the other hand, in this particular study, looking at the 4-drug combination that includes atezolizumab, the EGFR and ALK positive patients have a hazard ratio for progression-free survival of 0.59, and that is every bit as good, in fact numerically slightly better, not a real difference, but every bit as good as the wild-type population. When we look at the T effector high gene signature population, as I mentioned, the hazard ratio is 0.51. That's really far superior to the hazard ratio of 0.76 in the low T effector gene signature, although still a benefit for atezolizumab. When you look at PD-L1 expression, you also see that those patients with high-level PD-L1 have a hazard ratio of 0.48, so really in the same ballpark. And when you look at the zero PD-L1 expression, it's more like the T effector low. You have a hazard ratio of 0.77, so still in the right direction, but not of the same magnitude as we see. So as we see in the higher T effector or high PD-L1. And then when you look at response rate and duration of response, it's interesting that in the T effector high gene signature population, you see perhaps a little better response rate, but the bigger difference is in the duration of response, where it's a median duration of 9 months with the 4-drug combination, but in the broader intent to treat population. But in the T effector high group, that 44%, it's over 11-month duration of response. So again, another indicator of a greater degree of benefit in a defined subgroup, here T effector high gene signature. So what can we conclude? Obviously, we aren't going to be using T effector gene signature as a standard biomarker to make clinical decisions just yet. But we are going to be getting more information as this particular study matures, and there is a whole panel of other empower studies with atezolizumab in combination with other chemos and various other settings that are going to build in this T effector gene signature. We'll have to see whether, like tumor mutational burden as being studied in the trials with nivolumab and ipilimumab by BMS, whether the T effector gene signature holds up as a consistently reliable association that can help us identify which patients are most likely to benefit from immunotherapy, and ideally so that we can identify the patients where we should prioritize immunotherapy as a first-line treatment versus potentially deferring it to a later option for a prospectively defined subset. So we're going to learn much more soon, and I hope you'll stay tuned. In the meantime, I hope you'll like, comment, and ideally subscribe to this series. Hope to see you again.